Can start your presentation.
Yes, sir. Thank you, sir. Good evening, sir. Respected professor, my dear students. I welcome you all to another session of RISA DNB online academic activities today. Today we have a long case to be discussed and a short case. First, I invite Dr. Soundharya to discuss the management and anesthesia for operative surgery of a 24-year-old Primi diagnosed to be having moderate mitral stenosis at 21 years of age is admitted at 34 weeks of gestation with shortness of breath on mild exertion. Over to professor and students. Dr. Soundharya, please.
Yes, sir. Good evening, sir. My discussion is mitral stenosis complicating or medical disease complicating pregnancy. She's on third trimester. Now, known case of mitral stenosis at 21 years of age, and she's on moderate mitral stenosis. Normal mitral valve area is 4 to 6 centimeters square. Mitral stenosis refers to decrease in mitral valve area, and most common cause of mitral stenosis rheumatic heart disease and rheumatic fever. Other causes include congenital mitral stenosis and rheumatoid arthritis and systemic lupus erythematosus. Mitral stenosis is a continuous, slow, progressive disease, mostly present in second or third decade, and atrial fibrillations are most common. On evaluation, and aim of evaluation is assess the risk and stratify the risk, reduce the risk, and management the complications. It includes cardiac history, physical examination, functional status of the patient, and further investigations. Coming to history and physical examination, we should focus on the patient's effort tolerance and past history of any cardiac failure and any arrhythmias. Coming to the rheumatic fever history and prophylaxis, because patients are already diagnosed moderate mitral stenosis, I would like to ask patient first when she was diagnosed first, whether it is incident or any symptoms. Our patient is continuous any prophylaxis treatment, or still she is continuing, or any joint pain. Symptoms wise, any history of easy fatigability, syncope, or low effort tolerance because of decreased cardiac output. Any history of cough, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and hemoptysis because of increased left atrial pressure, and any history of leg swelling, and any history of leg swelling, edema due to right heart failure, and any history of hoarseness voice due to left atrium enlargement, and any history of chest pain, palpitations due to right ventricle ischemia, and severe pulmonary hypertension. Signs include, coming to the signs, on inspection, mitral phases, it is a mild sinus of lips and cheeks and malar prominence. It is less seen in the Indian females. And increased JVP, pedal edema, ascites, hepatomegaly, we have to rule out. It could be right heart failure. And palpation, pulse is normal and regular, low volume pulse. In case of atrial fibrillation, it is irregular pulse. Tapping apex beat and diastolic thrill is present in mostly left lateral position. Right parasternal heave is present due to right ventricular enlargement. And bad is bad. S1 becomes soft, loud pulmonary hypertension, sinus rhythm. It is a good indicator of mitral stenosis severity. Murmur, it is a low diastolic murmur, diastolic attenuation in the apex of it, best heard in the apex of the heart and in left lateral position with the help of bell of the stethoscope. Coming to investigations, routine investigations like complete blood count, LFT, RFT, and serum electrolytes to see, especially serum potassium, to see effects of diuretics and digoxin. Coming to the ECG, P mitral, that is the bifid appearance of P wave in lead 2, 3, and AVF. It is a left atrial enlargement. In case of atrial fibrillation, there's absence of P waves, and right axis deviation, right ventricular hypertrophy. Cyst X-ray is mostly contraindicated in pregnancy, but it's indicated only when it can take only on abdominal shielding. Usually it is normal, but slightly enlarged cardiothoracic ratio, and the straightening of the left heart border, enlarged pulmonary conus, and small aortic knuckle, and elevation of the left mainstem bronchus, and a Mostek sign or double density sign. Coming to echo, we have to see thorough mitral valve area, leaflets, any calcifications, and any septal wall motion abnormality, and left atrial enlargement, right ventricular enlargement, if any thrombus present, or pulmonary arterial pressure and pulmonary hypertension. With the help of the echo, we can grade the severity, mild, moderate, and severe. In my case, moderate is 1 to 1.5 centimeters square valve area. Others less commonly used investigations are cardiac enzymes, it's not routinely done, and the cardiac MRI, and CT also contraindicated. Cardiac catheterization is restricted to the interventional procedure with abdominal shielding. This stratification score, Corpex score, and the Zagara score in congenital heart disease, and NIGA score, and modified WHO classification score. Patient presents on SOB and mild exertion with a moderate MS, NIGA class 3 score, it is a high-risk pregnancy. Coming to the management, it is a multidisciplinary approach, and the team includes obstetrician, cardiologist, and anesthesiologist. This pregnancy should be deferred or termination of pregnancy for severe or symptomatic MS and with severe pulmonary hypertension. In patients with mild to moderate mitral stenosis is well tolerated and can be managed with medical management. It can be done with percutaneous mitral commissurotomy or balloon mitral valvotomy with the help of echo grading Wilkins mitral valve score. It can be usually done under 12 to 24 weeks. This can done before preconception also. Medical management includes bed rest, salt restriction, and diuretics, anticoagulation, warfarin, and cardioselective beta blockers, calcium channel blockers, and resorption to control rate and rhythm. While prescribing the drugs, we have to see the fetal side effects also. Anticoagulation in pregnancy and first trimester, unfractionated heparin or low molecular weight heparin. Unfractionated heparin is most preferred. Second trimester, oral anticoagulants like warfarin. And we can prescribe low dose aspirin for second trimester and third trimester also. At 36 weeks, warfarin should be stopped and bridged with low molecular weight heparin or unfractionated heparin. Goals and pre-optimization, it includes maintain sinus rhythm, maintain systemic vascular resistance, avoid increased PVR like any pain, hypoxia, hypercarbia, acidosis, and hypervolemia. Maintain low to normal heart rate, that is 60 to 80 per minute. Treat atrial fibrillation if indicator. Avoid increase or decrease preload. Hypervolemia, it leads to pulmonary edema, and hypovolemia, it leads to decrease the cardiac output further. And avoid atriocaval compression. Pre-op optimization, you have to evaluate fluid status and stop diuretics night before surgery and check electrolytes, especially serum potassium, on the day of surgery. We should continue resorption, beta blockers, and calcium channel blockers. Low molecular weight heparin, we have to withhold whether it is therapeutic dose 24 hours before surgery. If it is prophylactic dose 12 hours before surgery, we have to withhold. Unfractionated heparin, withhold 4 to 6 hours before surgery. And the aspiration prophylaxis, antibiotic prophylaxis, and the DVT prophylaxis should concern. Infective endocarditis prophylaxis is not recommended. Only it is high risk. Only in high risk cases. Sedative and anxiolytic should consider to prevent tachycardia and should give judiciously and titrated doses. Hemodynamic monitoring is recommended whenever it is needed and continue for 24 hours after delivery. Coming to obstetric and anesthetic management, delivery, whether patient is going for vaginal delivery or cesarean delivery. Vaginal delivery is recommended whenever is possible, and we can use assisted vaginal delivery, vacuum or outlet forceps delivery to cut short the second stage of labor. And epidural labor analgesia, epidural labor analgesia is decreases sympathetic stimulation, and we have to titrate the epidural boluses with the close hemodynamic monitoring, invasive BP monitoring, and that we can avoid adrenaline test dose. Cesarean section, advantages avoids the hemodynamic consequences of labor pain. Technique of choice are central neuraxial blockage or general anesthesia. Central neuraxial blockage, spinal anesthesia is contraindicated in severe MS. And if in patients with moderate MS with valve area 1 to 1.5 centimeters square with no pulmonary hypertension, can consider epidural anesthesia or combined spinal epidural anesthesia. Combined epidural spinal anesthesia is recommended because to rapid onset and better analgesia and post-op pain control. Technique of general anesthesia, it is indicated patient is reficial to central neuraxial blockage or contraindicated to central neuraxial blockage and severe pulmonary hypertension with valve area around 1 centimeter square. We have to keep all emergency drugs keep ready and drugs and keep defibrillator already, sir. ASU1 monitoring with hemodynamic monitoring, invasive blood pressure monitoring, central venous blood CVP is not recommended. Difficult airway cord should be kept ready. Urine output monitoring, temperature monitoring, and fetal heart rate monitor at induction. Left lateral tilt with 15° or keep wedge under the right hip. Pre-oxygenation for 3 to 5 minutes and modified rapid sequence induction technique with scoline or rocuronium. Induction agent is ecomidate. It is a cardiac stable drug, and we can use thiopentone with graded doses. Avoid propofol and avoid ketamine. Avoid tachycardia and avoid minimal laryngoscopic response with the help of lignocaine 1.5 mg per kg or esmolol IV. And avoid nitrous oxide. Maintain anesthesia with oxygen and sevoflurane. Avoid halothane. And we have to titrated fluids, avoid fluid overload, and use titrated doses of phenylephrine or short-acting beta blockers. And sudden increase of cardiac output after the delivery due to auto transfusion of blood of 300 to 500 ml, which leads to fluid overload. So we can give a small amount of diuretics, furosemide 10 to 20 mg IV. And injection oxytocin is administered as soon as the baby delivered. We have to avoid ergometry, and extubation should be smooth and avoid hemodynamic fluctuation. Post-op management, continue post-op management in 72 hours in HICU, and continue inotropes vasodilator support for 24 to 48 hours, and strict urine output monitoring and intake output charts should maintain and avoid overload. Avoid shivering, it increases oxygen consumption 300 to 400 times, and it increases the oxygen supply and demand balance. So oxygen support, consider oxygen support in post-operatively. Multimodal anesthesia with paracetamol, NSAIDs or systemic opioids, and we can use a TAB block, transverse abdominis block and the quadratus lumborum block, and already placed epidural anesthesia. And early mobilization, reception of anticoagulation and DVT prophylaxis. Thank you, sir.
Very good. It was like a rapid fire presentation going in Vande Bharat and Pratap the speed. Very good. Now, what are the normal physiological changes in the cardiovascular system which are going to be harmful in a patient with mitral stenosis?
At the end of the first trimester, to 30 to 50%, and it will peak at 24 to 32 weeks, and it increase on the first third trimester, sir, and increase heart rate, increase heart rate to 10 to 20%, increase stroke volume, and increase cardiac output 30 to 50% during third stage of the labor and during post immediate delivery, sir. And physiological say and SVR. SVR also decrease SVR, sir. And auto transfusion of blood 300 to 500 ml will lead to sudden decompensation, sir.
When will this auto transfusion occur?
After delivery.
Supposing she develops labor pains and contractions, will this transfusion occur? Auto transfusion occur?
No, sir.
There is a possibility of blood being pumped back into the maternal circulation even during labor contractions. But the final complete pushing back the blood will happen after delivery of the placenta when the uterus goes into contraction to prevent postpartum hemorrhage. On the contrary, every labor pain contraction will push at least 300 ml of blood back into the maternal circulation, which can be tolerated by the normal mother, but not a mother with a mitral stenosis.
Yes,
so this is a case of moderate mitral stenosis. The questions that can be asked in this can be in the form of physiological changes in pregnancy in the various systems, with a common question that will be asked in any pregnancy case given to you, despite whether it is a cardiovascular complication or anemia complicating pregnancy or a preeclampsia complicating pregnancy, whatever be the comorbidity that is occurring in a pregnant woman, you must always be prepared to face the question, what are all the normal physiological changes that are present in the various systems? That should be the first question that may be asked. The second question that you have to expect in these patients is all details about rheumatic fever and the rheumatic cardiac diseases. Okay?
Yes, sir.
So what is rheumatic fever?
It is
How do
the
you
acute,
define rheumatic fever?
it is acute non-suppurative immune-mediated inflammation of group A beta hemolytic streptococcus preceded by sore throat or any respiratory infections, sir.
Will all patients getting sore throat will be getting rheumatic fever sequelae of cardiac cardiac and or cardiac valvular involvement?
No, sir. Mostly they will self-limiting after 2 to 4, 3, 6 weeks, sir. After 6 weeks or 3 months, it will lead to mitral stenosis, sir.
So what is the percentage of patients who will be affected with the cardiac sequelae if they develop rheumatic fever?
1%.
Why they are only affected?
Less than 1%, sir.
Less than 1%, because they are immunogenetically inclined to get that particular complication. Thus may be having,
Yes.
because this is an autoimmune process. Why it is called autoimmune
Yes, sir.
process? Rheumatic fever.
There is a
why is
molecular
it
mimicry
called
between. There is molecular mimicry between streptococcal antigen and self antigens. The antibody against the.
Very good. So that is the particular terminology that you have to use in your answer called molecular mimicry. It is happening. The proteins that are being secreted by the Streptococcus mimic some of the proteins that are considered as alien or outward coming from the other exogenous sources, and that is the reason body creates antibodies against those antigens. And why the mitral valve is the most commonly affected?
Mitral valve is the largest valve, and it has more fibrous tissue, and it leads to high pressure valve and wear and tear issues due to more blood flow, sir.
Blood flow, yes. More shear force and blood flow happen in that particular region. What are the criteria to diagnose rheumatic fever?
There are 5 major and 5 minor, sir. Criteria name is modified zones criteria. Major criteria is migratory polyarthritis and syndrome scoria, pancarditis, and erythema marginatum, subcutaneous nodules, sir.
Nodules, very good.
Nodules. And 5 minor, increased ESR, fever, increased ESR, increased C-reactive protein, and leukocytosis, and a prolonged PR interval on ECG. That should be 2 major and 1 major, 2 major or 1 major and plus 2 minor should be present, sir.
Supposing this patient is willing to undergo balloon valvuloplasty of the mitral valve stenosis, what is the first and foremost thing that has to be checked?
We have to
she is now 25 years old.
Yes, sir.
And she was diagnosed to have mitral stenosis at the age of 21.
Yes,
now, surgeons advise, cardiac surgeons advise that she can undergo interventional procedure in the form of balloon valvuloplasty. What are all the things that has to be fulfilled to say that she is fit for balloon valvuloplasty?
It should be done on 12 to 28 weeks of pregnancy, sir. 12 to 24 weeks of gestation, sir, we should do, sir. And if it is indicated a moderate to severe mitral stenosis.
No. My question is, what are the criteria to say that the patient can be taken up for balloon valvuloplasty? What are the criteria to be fulfilled?
Symptomatic mitral stenosis with moderate or severe mitral stenosis, sir.
Is it the one which you have to take into consideration? Supposing patient still has got rheumatic fever activity, rheumatic fever process is still not yet over. Is it advisable to do a valvuloplasty at the time? So how do you assess whether the patient is free from rheumatic fever or not?
Whether the patient is taking any prophylaxis antibiotic.
Any objective testing or investigation which can prove he is free from rheumatic activity in the body.
ASO type.
ASO titer, yes, very good. ASO titer has to be checked and make sure that patient is first of all free from rheumatic activity. Otherwise, it will recur again. Once you do that also, because still the ongoing rheumatic activity is there, it will again go into stenosis and it will recur. Then second criteria, what is Wilkinson score?
It is a echo helper with echo guiding, sir. Leaflet thickening and any calcification of leaflets and subvalvular thickening, sir. We have to score the area, and if it is less than 9, it is mild risk. If it is more than 11 score, it is severe score, sir.
So what are
the patient?
Is there a way clinically can you identify whether the valves are pliable or not? Fit for balloon valvuloplasty? What auscultatory finding will tell you about the nature of the valves?
Soft S1, sir. If it is badly diseased valve. S1 should be soft, sir.
Softness.
First short sound.
Opening snap. Opening snap is an important thing to be. If this is not very prominent, that means the valves are become very much calcified. They don't make a noise. Whereas when the valve is flappy, it will make a nice noise and you will get a strong opening snap sound. Okay. So clinically you can identify using the Wilkinson score, and if all these criteria are fulfilled, then she will be fit for balloon valvuloplasty, which can be done even when the third trimester is there, because it is not a major procedure. You can do it even during the third trimester. But now here in the question we have given she is admitted at 34 weeks with moderate shortness of breath. Now, is it advisable to deliver the baby as early as possible or wait for her some more time? Treating her by medical. Huh?
You have to wait till lung maturity. So lung maturity will happen under 34 weeks. So we can proceed for termination of pregnancy after 34 to 36 weeks of gestation. Sir.
So if you plan to deliver the baby now, either by operative delivery or by your vaginal delivery, what is the treatment to be given to the fetus? Is there anything to be done to the fetus? Because it's only 34 weeks. Lung maturity will not be there. So what do you do for that?
Steroids. Dexamethasone.
You have to give betamethasone 10 milligram for 3 days.
2 doses.
Okay? So until then you have to manage her medically and then plan for a delivery. If she wants only a normal vaginal delivery, if she is not willing for cesarean section, how are you going to manage that patient?
Vaginal delivery, we have to assisted vaginal delivery, sir. And we have to keep anticoagulation. Whether this patient is taking anticoagulation, we have to check and monitor the PT, APTT, and INR, sir. Then we have to decrease the sympathetic stimulation, we have to keep epidural labor analgesia, sir.
So labor analgesia plays a very, very important role if the patient insists on having a normal labor. Supposing she develops atrial fibrillation now, how do you manage that?
Atrial fibrillation, first we have to see the patient is hemodynamic stable.
First of all, how do you identify the patient has developed atrial fibrillation? What are all the complaints the patient can make?
Palpitation, sir.
Palpitation, sir.
Palpitation, yes.
And irregular pulse.
Irregular pulse patient will not be able to say. They may say, I am having a palpitation, my heart is beating like mad.
Syncope. Yes, sir. Palpitation, syncope.
Giddiness, I mean, syncope and giddiness are all same. Yes, okay. And how do you confirm the diagnosis of atrial fibrillation?
We have to see the pulse, irregular pulse and pulse deficit. And in ECG, there is no P wave and irregular pulse, sir.
Okay. What are the types of atrial fibrillation?
There are 3 types: paroxysmal, persistent, and permanent atrial fibrillation.
Okay.
And acute
So
and chronic.
how do you differentiate between these 3?
Paroxysmal atrial fibrillation is self-limiting. The patient is unaware of their symptoms, sir. It's mostly self-limiting. And permanent atrial fibrillation, this needs to chemically cardiovert to sinus rhythm. And if a patient is having a persistent atrial fibrillation, long-standing atrial fibrillation, or a patient is not undergoing for any cardioversion, or it's not any attempted.
So what are the basic pillars of treatment of atrial fibrillation?
That is rate control, rhythm. First patient is hemodynamic stable or not, and rate control, rhythm control, and anticoagulation, sir. Rate control is more than rhythm control.
Okay. So supposing her BP is little fluctuating and her heart rate is very high, and you decide to do electrical conversion, cardioversion. How do you do that in this patient?
Cardioversion is the electrical impulses to convert the synchronized cardioversion in the R wave. It is synchronized with R wave or QRS complex, sir.
Yeah, your ECG defibrillator will have all that facility to identify the R wave and deliver the shock. That you need not worry about. But in a pregnant, 34 weeks pregnant woman, if there is a need to do cardioversion, how to do that?
First, we have to keep the pads.
What are all the precautionary measures you have to take?
We have to avoid.
Can the patient have a meal and then can you do a cardioversion at the time? After a full meal?
No, sir. It is an elective procedure, sir. We have to.
So preferably, patient should be at least having a starvation of 4 to 6 hours. Then anesthesia or it is done awake?
Mild sedation we have to give, sir.
Mild sedation you have to give, and all resuscitative equipment you have to keep ready. What is the amount of current or strength of the current you will employ for cardioversion?
Low joules, sir, 120 joules.
100 to 120 joules.
Yes,
okay, and that may be not very painful.
Yes,
and you have to keep all the airway gadgets and other resuscitative drugs ready. Yes, and sir. Have some helping hand also to do this.
Yes, sir.
Supposing she has a very severe mitral stenosis, this is an hypothetical situation where she has a very severe mitral stenosis and the cardiologist has already advised her to go for mitral valve replacement. What is and she now lands up with a severe dyspnea and impending pulmonary edema. What is the mode of managing this patient?
Our choice is general anesthesia, sir. We should not give central uraxial blockage. And after cesarean delivery, we have to plan for cardiopulmonary bypass, sir.
Can both the procedures be taken up simultaneously? Operative delivery and the valve replacement?
Not simultaneously. After that, we have to do so.
No, if it is very severe mitral stenosis, it is advisable to go ahead first to do the cesarean and deliver the baby, and in the same sitting, can she undergo open heart procedure and valve replacement?
I do.
In well-equipped centers, they do that. Where there is a full cardiac facility is there, they plan it that way only. They first deliver the baby by cesarean section with the help of an physician. Then in the same sitting, mother will be need to undergo valve replacement also. Okay,
Yes, sir.
and mitral valve repair has been done. Even cardiac transplantations have been done in such things in cardiomyopathy cases. Okay, so that is not an issue, but you need all the facilities and the backup for all these high risk procedures done together. Okay? So nicely brought out all the points.
Yes, sir.
I just now share my screen with you.